Good morning. Today, we have two recognized leaders in health disparities and outcomes who will be speaking on their experiences in addressing health disparities in a system-wide approach from both the neonatal and maternal perspective. First, we have Dr. Rachel Hardeman. Dr. Rachel Hardeman, who is an assistant professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. She is a reproductive health equity researcher whose programs of research applies the tools of population health science and health services research to elucidate a critical and complex determinant of health equity, racism. Her overarching goal is to contribute to a body of knowledge that links structural racism to health in a tangible way. She identifies opportunities for interventions and dismantles the system, structure, and institutions that allows inequities to persist. Dr. Hardeman is active locally and nationally with organizations that seek to achieve health equity. She was recently appointed to the Minnesota Maternal Mortality Review Committee and the CDC Maternal Mortality Review Committee on health disparities. And she is working to develop a measure of structure racism to be included when reviewing maternal deaths. Dr. Hardeman also serves on the board of directors for Planned Parenthood. Next, we'll have Dr. Jochen, who graduated from the University of Freiburg Medical School in Germany and completed his neonatology and health service research at Harvard. Since 2013, he has been on the faculty at Stanford and is currently an associate professor of pediatrics there. He also serves as Chief Quality Officer of the California Perinatal Quality Collaborative. Dr. Profit's research focuses on optimization of quality of neonatal perinatal health care delivery. For over a decade, his research has received continuous funding from the National Institutes of Health and other federal foundation and intramural sources. Dr. Profit has served on various scientific and professional organizations, including the National Academy of Sciences and the National Institute of Health. The next slide, please, will show the objectives of this panel. The next slide will show the objectives of this panel. First is to discuss the importance of addressing racial and ethnic disparities in neonatal and maternal outcomes. And secondly, to identify steps or policies to narrow the racial ethnic disparity gap in these outcomes. The next slide shows where Dr. Hall yesterday presented the overall mortality statistics for both mothers and babies. Today, I just want to emphasize two slides showing the persistent, unrelenting racial ethnic disparity gaps in both this slide, which shows infant mortality, and the next slide, which shows maternal mortality rates in the state of Texas. These aren't just lines, but they represent unnecessary deaths of Texas mothers and babies. The next slide shows how Dr. Liu challenged us to do what this data will look like in this newspaper caption. What will the data look like in disparities in the next 10, 20, and 30 years? And I could not help but remember this is a young Dr. Guillory in 2007, working with the March of Dimes and the Honey Child Project to decrease Black premature births. This same newspaper caption today can actually say the very same thing. The next slide is one I'm very proud of. This is my 2-week-old granddaughter. And it is hard for me And it's hard for me to understand and certainly explain to her that just because she was born black, she has a 2 to 3% chance of dying than any other child. And as a grandmother who knew those statistics, what I had to go through throughout the pregnancy. The next slide shows that something we can't ever forget. As we in the collaborative and overall do research, we really have to understand it's not just maternal mortality and it's not just infant mortality, but the two are intertwined. So when we look at things, we have to understand that maternal mortality have a trickle-down effect affecting our babies. Today, Texas, the next slide, is working, thank you, Dr. Hall, is working very hard to combat these statistics. But, on the next slide, we have a responsibility as individuals as well. Now I'm going to turn the podium over to Dr. Hardeman and to Dr. Prophet as we challenge the problems with our mothers and babies in Texas. Dr. Hardeman.
Good morning, everyone. I'm so happy to be here. It's a lot warmer here than Minnesota. Although it's warming up, 40 degrees for us, and we're in short sleeves. But so I am going to share a little bit about the work that I've been doing both in Minnesota and across the country around addressing maternal and infant health inequities, reproductive health inequities. So I think we can get the slides started. That would be great. We can probably skip the first couple of slides. So, oh, this is not my slide deck. Yeah. Well, I can get started while we while we wait. So I think the first couple of slides just share that I don't have any conflicts of interest, but I wanted to start, I think we just heard some of the background of sort of the issues that we are grappling with, both here in Texas and across the country. This is not an issue that any state in our country is immune to. And if we look at the data, we can see that in just 4 short years for Black women, the maternal mortality rates have increased at least by 8.8 to 10%. And in Minnesota, we're also grappling with the fact that our indigenous moms are dying at even higher rates than African American moms. I'm going to pause for a second and see if we can get those slides going. I just saw a hand shrug up there. Okay, I will just continue. So, I had one of the other slides that I would have shown you to kind of sort of level set us and show what we're grappling with, really kind of explains how infant mortality in particular has declined. While it's declined since the 19th century, the disparity or that gap between Black and white infant deaths today is actually greater than it was during antebellum slavery. So historical demographers estimate that in 1850, enslaved infants died before 1 year of age at a rate that was 1.6 times higher than that of white infants. We're on slide 4. Thank you. Sorry, now I just lost my place. So, I think what we have to understand is that and what I think this graph, particularly the infant mortality chart, really shows us is that this is a historical problem. This is not a new thing. It's new in the sense that I think we're talking about it, and it's become part of the conversation in popular media, which is wonderful and important, and I think is leading to a lot of resources and efforts from a policy perspective. But this issue of infant mortality and maternal mortality, and particularly the inequities by race, is rooted in the history of our country. Next slide, please. So this is a point where, in my talks, where often folks get really uncomfortable because I'm going to ask you to consider that our maternal and infant health crisis is deeply embedded in the history of racism in our nation. And we have to reconcile this and understand its connection to contemporary inequities in a way that offers solutions that don't blame Black birthing people or Indigenous birthing people for their outcomes. So as many of you may know, 2019 marked the 400th anniversary of a pivotal event that shaped our country, and that was the arrival of the first slave ship to America. So in 1619, a group of 20 Africans were sold into bondage in Jamestown, Virginia. Next slide, please. So we might argue over how different America might have been had our country never embraced the belief that white people are superior to those of all other races, also known as white supremacy, or that what would have happened if we hadn't embraced race-based slavery. But we certainly cannot argue that this history has not fundamentally shaped who we are today. And I think these timelines show an important example of that. So as you can see, our Black enslavement comprised 60% of our country's history, and Jim Crow, so state and local laws that enforced racial segregation, makes up 20% of our nation's history. These timelines, I share them because I think they're a reminder of how deeply ingrained our history is and all of the ways that white supremacy has taken new shapes and forms in order to maintain the status quo, and that is inequities in maternal and infant health for Black people in our country. And today we see it show up in places like mass incarceration, the war on drugs, and many other social issues that plague our society. And a lot of the work that I do really thinks about how making those connections. So looking at how mass incarceration, how police violence, and other population level issues that have a racialized lens are impacting the health outcomes and reproductive health outcomes of Black communities. Next slide, please. So there's an underlying assumption that upholds white supremacy, and it's one that is pervasive in medicine. I would say less so as we move through thinking and rethinking our curriculum, but we still have a lot of work to do, and that's that race is biological. In fact, we learned from a 2016 study out of University of Virginia that medical students and medical residents who endorse this and other false beliefs about Black people, perhaps having thicker skin or not feeling pain, were more likely to rank higher on the implicit racial bias tests, or the implicit association tests. Next slide, please. But more accurately, race is a social fact. It has nothing to do with biology. It's not a thing that people are or have. It's an action. It's something we do. It's a way we define in-groups versus out-groups. It helps us define us versus them. It allows for group membership and certainly shapes our experiences and access to opportunities, everything from education, employment, where we're able to live, the jobs we're able to access, the resources we're able to leverage, our social networks and social capital, and certainly our health outcomes. There's no gene or cluster of genes common to all Blacks or all whites. For example, if race were real in a genetic sense, racial classifications for individuals would remain constant across boundaries. Yet, a person who could be categorized as Black in the United States might be considered white in Brazil or colored in South Africa. Next slide, please. So then, what is at the root of the fact that Black birthing people are at such high risk for death and or complications during and after childbirth? You can advance, please. And I would offer that race isn't a risk factor in maternal and infant health, racism is. Next slide. So by racism, I mean the systems of structuring opportunity and assigning value based on phenotype or race that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and undermines the realization of the full potential of our whole society through the waste of human resources. And like other epidemics, structural racism in particular is causing widespread suffering, not only for Black people and other communities of color, but again for our society as a whole. It's a threat to our physical, to our emotional, and social well-being, and allocates privilege on the basis of race. And I think what's important to note about this slide is the figure, the circular figure, that shows us that it's critical that any learning about implicit racial bias, because I'm sure all of us have talked about it at some point, right? Show of hands. We know what implicit racial bias is, right? I think it's become an important buzzword over the past few years, but our failure right now is that we're not linking it to the structural and the systemic issues that are underlying and propping up why implicit biases exist. So we have to both understand the social psychology behind implicit bias while also understanding the context of structural racism that gave rise to it and perpetuates inequities and those harmful racial biases. So as leaders for health equity, I would submit to you that we have to examine, unpack, and mitigate our own biases while simultaneously dismantling the policies and structures that uphold inequity and biases in the first place. So how does the confluence of implicit bias and structural racism show up in healthcare delivery for moms and babies? I'm going to share a couple of examples. There's plenty more out there, and I'm sure just given the sort of popular press stories that have been shared over the past few years, like that of Serena Williams, you're all familiar with some of them. So the Giving Voices to Mothers survey or study, which was conducted out of the Birthplace Lab, Saraswati Vedam, in Canada, in Vancouver, but the survey actually was international, and these results are from experiences from women birthing in the US. And they found that 1 in 6 women reported experiencing one or more types of mistreatment, such as loss of autonomy, being shouted at, scolded, or threatened, and being ignored, refused, or receiving no response to requests for help. The rates of mistreatment for women of color were consistently higher, even when examining interactions between race and other maternal characteristics. For example, almost 30% of women of color with low SES reported any mistreatment versus 18 or 19% of white women with low SES. So regardless of maternal race, having a partner who was Black also increased reported mistreatment. And this is the first study to use indicators that were developed by service users to describe mistreatment in childbirth in the US. The findings suggest that mistreatment is experienced more frequently by women of color when the birth occurs in hospitals. The next piece of evidence I want to share with you is from a paper that my colleague, Dr. Atanasio, and I published in the journal Social Science and Medicine. And what we sought to investigate was the birthing people's experiences of declining procedures in maternity care. So what happens when someone decides, no, I don't want to have that particular procedure done, or I don't want that done for my newborn. And so using a national sample of women who gave birth in the US and hospitals in 2011 to 2012, so the Listening to Mothers survey, we found that women who reported having declined care for themselves or refusing care for themselves or their infant during the childbirth hospitalization were more likely to report poor treatment based on race and ethnicity, based on insurance status, or having a difference of opinion with the healthcare provider. Moreover, the increase in odds of perceived discrimination due to a difference of opinion with the healthcare provider was significantly larger in magnitude for Black women compared to white women. Our findings suggest that in the context of childbirth care, women pay a penalty for exhibiting behavior that may be perceived as uncooperative, and this penalty may be greater for Black women. The potential consequences of this are likely worse for women of color who are already expending a great deal more effort to manage their image during healthcare encounters in order to avoid the stereotype of the angry Black woman. Next slide, please. And in our work in Minnesota studying a community birth center, so a freestanding birth center that's one of 5 African-American owned birth centers in the country, we examined their culturally centered model of care. And we sought to understand the ways that we can bring that model of care into other settings like the hospital setting to improve the experiences and the outcomes and the mistreatment that we just learned about. And one of the things we found in this work, and I encourage you all to read our paper that was just published in Birth fairly recently around the intersections of relationship-centered care and critical race theory. And in this paper, we write about a call to action that describes sort of the 4 principles of relationship-centered care that were outlined several years ago by researchers at Johns Hopkins, Mary Catherine Beach and Lisa Cooper. But we describe it through a critical race lens in the context of pregnancy and childbirth care. Because taken together, we believe the 2 concepts can have the potential to powerfully reduce racism's impact on childbirth outcomes for Black birthing individuals, infants, and families. And I'm happy to talk about that more as we have our Q&A session, but in the sake of time, I won't go dig into the details of it. Next slide, please. Finally, I want to close by sharing what myself and my colleagues published several years ago in 2016, just after Philando Castile was shot and killed in our community in Minneapolis and St. Paul. And our goal was to ensure that our colleagues, so our clinician colleagues and our researcher colleagues, recognize that we cannot live our lives pretending as though we don't have a role to play in supporting Black lives, and I would add Black motherhood. So we wrote this call to action, really laying out the first steps, the first 5 steps we believe that we can take as researchers and as clinicians to begin to provide higher quality care and the best quality care we can to our communities and our families. So the steps we laid out were first to learn and understand and accept America's racist roots. I gave you a little sort of precursor to that and how I teach that in the classes with public health and medical students, with the idea that it's both a collective and our individual responsibility to understand the history and the historical roots of contemporary health disparities. Next, we offer that you have to understand how racism has shaped the disparities narrative. Again, implicit bias and false beliefs are common. We all hold them. We all have biases, and it's incumbent upon us to challenge these beliefs when we see how they contribute to health inequities. Next, we offer that we have to define and name racism. 3 years ago, I did a study that was published in Public Health Reports that found in the top 50 public health journals, racism had only been named about 25 times in 25 articles over about a 10 to 11-year period. So we, as a field in public health and medicine, we have to be able to get comfortable naming these issues and really identifying them, because if we can't name them, we can't talk about them, and if we can't talk about it, we can't fix it. Next, we have to recognize racism, not just race. We often talk about the race of our patients without understanding the context of how race shows up in their lives and impacts them. And it also, I think it also sort of allows us to stay in this victim blaming place of saying, well, they were non-compliant, right? Or they didn't take their medicine, or they didn't follow my orders. And without really understanding how racism is playing out in the lives of those communities, we can't understand why someone may not have been compliant. And finally, we offer that we have to center at the margins. And centering at the margins in healthcare and in research requires anchoring and engaging within the experience of disenfranchised groups to yield a shift in the discourse that typically subordinates them to the dominant race or culture. Centering at the margins in clinical care and research necessitates redefining what's normal. So thinking about what our comparison groups are. I have a colleague who always says, she's a midwife, and she says the goals she's aiming for are to have outcomes that look like those in the Netherlands, not necessarily the white comparison group that we often talk about when we talk about racial disparities. And I think to do that, we have to employ a critical self-consciousness, so the ability to understand how society and history have influenced and determined the opportunities that define our lives. So for clinicians, that means reflecting on how you arrived at the understanding of a diagnosis or clinical encounter, and having a willingness to understand how your patient may have arrived at something different. The ability to center at the margins represents not only an important opportunity to practice an elevated level of patient-centered care and relationship-centered care, but it also reveals how new findings and clinical insights and the experiences of those often overlooked or harmed by our institutions. So I'm gonna close by just thanking my awesome collaborators. These are just a few of the many folks that I work with and help to lift up the experiences of birthing people in our communities. And my last slide is just a few resources if you're interested in reading more. Thank you.
It's hard to follow. Good morning, everybody. So I'm Jochen Profit. I really wanted to say thank you to Mike Spear and Charleta Guillory for inviting me back to Texas. Charleta, you know, before you guys throw eggs at me, coming from California and thinking, what's this tree hugger doing here? Just wanted to mention that I spent 8 years in Houston at Texas Children's, and 3 of my 4 children are Texans. So there you go, y'all. All right. All right. I do have some NIH funding. In the interest of time, I'm going to pass over that, but we've done a fair amount of work with federal dollars on defining really care delivery and disparities or racism in care delivery. I am the Chief Quality Officer of the California Perinatal Quality Collaborative. And since you guys, I'm so excited that there's a Texas collaborative that's springing up and emerging. I really encourage you to continue on this route. And I just wanted to give you just a brief introduction on what we do, because we've been around for a little bit longer, but it's maybe one of the most exciting things for me and the reason really why I moved to California is to be part of this group. So we have about 500,000 births in the state. We're maybe a little bit bigger in terms of population, but Texas is a really large state and can make a big difference. We have 17,000 NICU admissions, 140 NICUs, about 240 maternity hospitals. I think there's a lot of obstetric providers here too, right? Nurses and obstetric providers. So we are also a perinatal group. As I'm sure you're well aware, we also collect data on transports. There's about 7,000 transports every year where babies get transferred. And we also have a high-risk infant follow-up program where throughout the state about 9,000 babies are seen. These are, your high-risk babies less than 1,500 grams and larger babies with various conditions. So we really get the population-based data on these babies, and we can use that data for benchmarking, audit, and feedback. So this is just kind of our dashboard, which is really informed by our providers. The providers get together, they tell us what they want to know about. I'm not going to go into a lot of detail, but here's like a variety of different metrics that they wanted to know about for their NICUs, and there's various ways and all these icons that they can drill into all of these measures. Here's the baby monitor, which we just brought online, which is a composite indicator of NICU quality, and you can kind of compare your own NICU against the rest of the state or NICUs like you. We then also try to really just turn data. Data is really at the basis of what we do, but we really try to turn data into improvement action. And so we do conduct collaboratives in various forms. They might be smaller groups or sort of like we have a big IHI collaborative about every 2 years, and the one that's currently sort of wrapping up in the next month is our Grow Baby Growth collaborative, where we focused on growth of very small babies. Over the last kind of, 10 years, this is in press right now, we've seen in California a dramatic decrease in several outcomes. I'm just showing you two. These are outcomes where we really haven't made a huge amount of progress in terms of new modalities of treatment. Maybe breast milk is more common now and banked milk, but 46% reduction here. Healthcare-associated infection, there's really no new wonder drug for this. This is all just quality improvement work that's been conducted across the state. The maternal side, I really don't want to forget them. Elliott Maine is its leader, and they're really famous for this graph, which shows California in relationship to the rest of the United States with regard to maternal mortality. And really where the line started splitting there is when there was a really concerted effort by CMQCC to look into each maternal death in the state and formulate ways to address these. This is a slide, I think, similar to what Rachel had shown us with regard to existing disparities. You had seen data already on maternal mortality. This year shows you severe maternal morbidity, and again, similar to what you've previously seen, severe maternal morbidity, which is a composite of multiple things that can go wrong for mothers during childbirth, is substantially higher for the Black community, also for the Hispanic community, which in California is by population, of course, a lot larger. Like nearly half, like 40+% of the population in California is Hispanic. The story, of course, for Black women in childbirth is that they're often not being listened to, and Serena Williams kind of represents this most. Here's a mother, a black mother who has a lot of agency, right? World famous tennis stars. You would think of any person, she would really be able to get any kind of treatment at the tip of her fingers. Yet, even though she had a history of blood clots in the past, it took a long time for her to convince her providers that when she was having shortness of breath, that she have a CT scan done, and so even with a high degree of agency, and this is what we hear from black mothers over and over again, it feels like the medical establishment is not listening to their concerns. And so we find this persistent disparity gap that Rachel already shown us. In the interest of time, is going to move beyond this. I'll show you kind of the framework of what we had been working with, and so on the left side of you, what's termed SDH, is really social determinants of health. And I think traditionally, when research has focused in the neonatal and perinatal field, most of the disparities research really has focused on those parts. So those are things like housing, transportation, access to food, education, rights, income, and the ability for children to play. All of these things influence outcome. A less really researched area, and especially in our field, has been that little, let's see if I have a pointer here, has been the little hospital here. Right, this hospital is, it's sort of assumed like we're kind of immune from this. We're just kind of recipients of different, like patients who come to us with different risk profiles, but we kind of treat everybody the same, and sort of any of the outcomes in the end that happen, we'd like these kind of healthy babies there. So, but any of these outcomes are just really influenced by anything that happens on these social determinants of health. And so we were really interested in kind of studying and in addressing this issue. For me personally, this was when I was a fellow, one of my co-fellows in Boston, Vincent Smith. We were both doing this health services research fellowship, and we had a lot of these presentations on disparities, and it was kind of always the same thing. It was like, yeah, if you're poor and if you're black, you have worse outcomes. And I was like, look, it's the same. We hear the same thing over and over again. Like, I just don't, like, is this really happening in the NICU? And Vincent said to me, you know what, like, you may feel like you're doing the same thing for all your patients, but you're not looking deeply enough. So go and try to keep an open mind, and I've tried to do that. And so like what I'm showing you kind of next is sort of the journey, my personal journey, and hopefully I can see or you can see whether your experience kind of reflects with that. Okay, so are there disparities in perinatal care? Well, one of the things is that with regard to bias, which Rachel mentioned already, is that we're all surrounded by bias in areas in our entire lives where the world as we perceive it doesn't come to us without a filter. And so is the NICU really a little social cocoon here, like in the corner, where we keep all of these biases out of our lives? Here's an example from Google with regard to bias. If you typed into Google, this has changed now because a lot of people have complained about this, but if you, like a while ago, typed 3 black teenagers into Google, you would get these pictures that kind of really look like kind of mugshots, right? This is like somebody who's going to jail pretty much. Whereas when you put 3 white teenagers into Google, you get these kind of happy-go-lucky, lucky sports playing teenagers there, right? So even in areas where we don't necessarily really expect it, like we're influenced by algorithms, and these algorithms are biased. So we conducted, Krista Sigurdsson, who is a postdoc in my lab, conducted a systematic review, scouring really the entire literature on articles in the neonatal field to see how many articles are there that specifically looked at disparities in care delivery and not just sort of in care outcomes. So we've this is published, and you can look at this, but we used a quality improvement framework from Donna Bedian which you might recognize as structure, process, and outcome, because you guys are quality improvers now, so you should know about this framework. And so, typically people say, well, the outcomes are different because of all the social determinants of health. But really, we also found a lot of articles, that describe difference in processes and differences in structures of care. And some of these things you can, if you want to name them, you can call these things structural racism or interpersonal racism. So what might be mechanisms for different care or disparate care in a NICU? Elizabeth Howell, who I deeply respect, was a fantastic researcher in New York, really wrote a very nice paper, kind of very succinctly laying out what the different mechanisms might be. So if you think about it, why are there differences, disparate care? It could be because vulnerable populations receive care in hospitals that don't produce care that's as good, low quality hospitals, right? So if we intentionally have patients being treated at hospitals that are not as good, that could lead to different care in terms of processes and outcomes. Or it could be that within a given NICU, patients receive different care just based on their race, ethnicity, or income, or sort of our judgment of their social value. And so Elizabeth Howell here in one of her papers kind of looked at all the hospitals in New York and used a sort of composite. This is all kind of public billing data, which I think you can also use in Texas. Looked at a composite of neonatal morbidity and mortality and ranked all of these NICUs. Each dot here with a bar is a NICU, and the sort of outcomes on this composite. And you can see that there's a wide difference here between like the ranked number 1 and the ranked number 39 hospital. And it turns out that about 40% of the black-white disparity and 30% of the Hispanic-white disparity really was explained in multivariate like regression models by birth hospital. So this is an example of between NICU or structural racism, between NICU disparity or structural racism. Here's a paper that we published last year where we looked in California at healthcare-associated infections and race, ethnicity, and we tiered those. And again, you can kind of see the sort of spread in like some very low infection hospitals, some high infection hospitals, but also what you can see is this wide gap within hospitals. Like some of these dots are. It's a little hard for me to see here. I think the whites are orange and black, so I think there's blue. So you can see essentially there's big gaps. So there's really within NICU disparity as well here. And so blacks were more likely to be cared for in hospitals with overall higher infection rates, and Hispanics were more likely overall to suffer from a healthcare-associated infection. We worked with Vermont Oxford, with Jeffrey Horber to look at national data, and this is kind of a complicated analysis which goes back to like the Gini index of inequality, but essentially what we looked at was like where are patients being taken care of, and if it didn't matter what your race and ethnicity is with regard to which hospital you'd be taken care of, everybody should be sort of on this middle line. And the fact that all of these different race ethnicities are substantially below this line indicates that there's a lot of racial segregation by NICUs. We also looked at quality indices in this with the baby monitor and also found substantially lower quality for black babies. So this is typically the time when somebody complains in the audience or stands up and says, but we treat everybody the same, right? And that's what I thought initially when I comes, like, I don't hardly, like, we just go from bed to bed and we do rounds and we just try to sort of do the same for everyone. So we actually used one of the talks that I gave at the Vermont Oxford meeting, and we just asked the audience, could you send us a brief story if you've experienced one when you observed what you thought was a racial ethnic difference in treatment. And we got, from over 1,000 attendants, we got over 300 stories sent back to us, the vast majority reporting an observation over the last 6 months. And the first thing to note was that when we talked about disparities, people included a lot of different dimensions here. It wasn't just race, ethnicity, it was language, it was social status, a whole bunch of different things that went into this. And then out of that came essentially 3 large negative sort of dimensions when we analyzed the data qualitatively that led to worse care. One of them was neglectful care, in which NICU staff ignore, avoid, or neglect family needs. For instance, breastfeeding support when it's just considered too difficult or unpleasant, or when obstacles were considered too great to overcome. Judgmental care is when staff evaluate a family's moral status based on race, class, or immigration. Circumstances or behaviors are judged more harshly. Discrimination occurs through staff attitudes or resource allocation. And then systemic barriers, where staff are either unable or unwilling to address barriers families face, such as transportation, childcare, housing, employment, translation needs, religious and cultural needs. Now, I just wanted to give you 2 examples in the interest of time. Here's one for an example of neglectful care. A Spanish-speaking mother of a 23-week infant was not provided with a translator either before, during, or after delivery to explain what was happening with her baby. I asked for an interpreter to come into the hospital to help and face pushback because it was late at night. The L&D staff thought a translator phone should be sufficient. I felt the situation would not have been met with such lack of empathy had the mother been of a different race ethnicity. And I would really encourage you to go to this paper. It's in 2018 Journal of Perinatology. There's an appendix in there where we just really collated all of these stories, and I feel like most of these stories have happened in my practice. And so it's really kind of harrowing to read through this. Judgmental care. I see this all the time. The way we treat black moms is definitely different than how we treat white moms. And age plays a factor too. Young moms are judged very unfairly. One black mom was judged very harshly for being late for a feeding, even though she had a long and challenging transit ride to get to the hospital. A white mother who was late on the same day was greeted with sympathy. A small example, but I see moments like this every single day. This is a family advocate regarding a family identified as black. So most of these accounts, though, really told about how we treat families differently, not how we treat patients differently. So maybe we feel like we really don't, we provide equal care, but we don't provide it to the families, and so the babies eventually, if we don't educate them enough, if we don't care for them enough, then eventually the babies become second victims. So some of the things that we have done in California now, we've, in addition to all the other kind of measures that we provide for membership, we've created an equity dashboard in which each NICU now can see the racial ethnic makeup of their population, and we actually measure for them and flag for them if there is a disparate outcome within their NICUs on any of the key measures that we found through a systematic review. This is an example from a paper that just came out last month, and for our OB colleagues, this is Elliot Main's work, where in 99 hospitals we implemented this maternity bundle of 17 different interventions and showed substantial improvements in maternal morbidity. But this sort of very technical quality improvement approach, without trying to really reduce disparities, actually led to a substantial decrease and an elimination, really, of almost of disparities in severe maternal morbidity in California. So some areas of disparities are just addressable through technical standardization of what we do. Other things that we might want to think about doing in the NICU, and we coined this in a framework of readiness, recognition, response, and systems learning, which was also the framework used for the maternal collaborative. So organizational acculturation to address the diverse population the hospital serves. This really comes back to leadership, like leadership up in the C-suite needs to ensure that disparities and health equity are an important part of their mission, and that it should permeate everything they do. Could we just have like signage or education materials that just flags that we have respect for all persons independent of what their race, ethnicity, or background? I'm sure you can come up with better signage than me, but could we just say in our NICU, you're welcome as a partner in your child's care at all times? We'd want to make sure there's counseling available to address the specific vulnerable patient needs. We'd like to have professional standardized assessment of social determinants of health and psychosocial support. One of the things that we actually interviewed mothers, and mostly mothers of families, vulnerable families, and one of the things they told us is that they're really ambivalent about the social workers that we love to work with. But they see them oftentimes as a threat. Somebody is going to take away their baby, and they don't really know what they do. They just come and ask them very personal questions, and then they oftentimes don't really provide them with any guidance about what they might be able to do for them. And so could we just standardize this process a little bit? Can we find support for transportation, parking, food, siblings, cultural sensitivity, so anti-bias training? I'm sure we'll talk about this later. I'm not sure I would put most of my money into this. The training, the cultural sensitivity has not been shown to really change health outcomes, and so you spend a lot of effort on trying to train people, but whether it pays off is not clear. Family-centered, family-integrated care. Again, can we do standardized? This comes also from parents. Standardized breastfeeding and skin-to-skin education. Parents don't know when they're allowed to hold their baby and when not. It just depends on which nurse is at the bedside, oftentimes, right? So can we find language concordance between staff? How many times have I taken care of a baby that's been taken care of by a nurse that doesn't speak Spanish? Across the room is a nurse that speaks perfect Spanish. And when we make the assignments, could we just check? And of course, it's not going to work every time, but if it's possible, could we just make sure we can communicate? Can we have family advisory councils that face the hospital, but also can they face the patients and support them with peer-to-peer programs, support programs? Can we do family-centered interaction with babies over phone and video? How many of you are doing videos in the NICU now where parents can see their kids through video? Just a few. Yeah, we're not doing it either. I feel like in 10 years it'll be like, why did we not do this all along? It's like a terrible thing. We have many families who come from over 2 hours away. They can't, it's not possible for them to be there every day. So, and then through the measurement, can we do audit and feedback of quality measures by race, ethnicity, and language capability? Okay, I'm going to run out of time. I know, you can kick me off anytime. Jeffrey Horbar and Andrew Beck and Erica Edwards from Vaughan published this paper. I just wanted to point you towards. They identified 62 things that you, as an organization or a NICU or a labor and delivery unit, could do. So go check that out and start something. So here's what we're doing in California. So the CMQCC is working on efforts in labor and delivery. Actually, respectful care is a big theme there, and there's surveys of moms measuring whether they felt like they were treated with respect, and there's a change effort to try to improve care for mothers. On the NICU side, we have several work groups focusing on between and within NICU disparities. We have one group that's focusing on safety net hospitals, and we want to do a collaborative of safety net hospitals, really bring them together and understand what their needs are. We have another group that's focusing on within NICU disparities, and we're using breast milk feeding at discharge as sort of the initial goal for that. And then we've had a group developing measures of family-centered care, because through our qualitative work we really found that it's really the family that requires equal and non-disparate care in order to improve equity. And then we have another group that's focusing on transitions and high-risk infant follow-up. So just in summary, we don't practice in a social cocoon. Disparities in NICU care exist within and between NICUs. We need to prioritize disparities. That's really like something institutionally and as providers. Be aware that these things happen all the time in our NICUs. We need to routinely measure processes and outcomes by race, ethnicity, incorporate disparities into all QI efforts. We can have an equity aim in all of our QI efforts. And we should engage our family advisors. And when you go home, try something out of the 60 plus things that are on this list, and try something out. Many of them don't have really any evidence yet because there's almost no literature on trying to reduce disparities in this setting. So it's a wide open field for young researchers, quality improvers, and professionals. Thank you very much.
Thank you both very much. We'll begin to open this up for question and answers, but I have one question for each of you. Dr. Hardeman, I read your paper on developing a medical school curriculum in racism. I do remember very distinctly giving a lecture to our neonatology group and using the word racism and actually being called afterwards, saying that it might be a little too toxic. So how do you deal with, number one, breaking down the structure at a medical school section, and yet these students have to go and practice in a hospital setting, and there you may not have as much control. So how do you deal with that problem?
So I think you just described exactly what the challenges are. And I think our students, medical students across the country are ready and are asking for this curriculum and are really interested and activated around all sorts of inequities. I mean, I think the White Coats for Black Lives is a really important example of sort of how these young folks are mobilizing and really thinking about what it means to practice medicine in 2020 and beyond. And the struggle, just as you described, is that they're trying to do that within systems that aren't maybe as far along, or in some cases are really resistant. And we ran into a lot of those barriers and are still dealing with that, and sort of teasing apart sort of how you bring sort of the institutions along with you. So, and then they're going out into the world where perhaps these conversations aren't happening at all. And so I think it's really thinking about all of the ways that we can infiltrate and infuse this work into all the aspects of training. And so at the University of Minnesota, even in our family medicine residency programs, similar sorts of training and discussions are happening. Just as they are with the first-year medical students with the curriculum that we've created and piloted there. But I don't know that there's one specific answer to that because other than we have to be working at this at all angles.
And the second question is for Dr. Prophet. As you well know, Texas is working with the Perinatal Advisory Council in developing and implementing the designation process for levels of care. One of the things that didn't come up is how we work with racial and ethnic disparities within the different NICUs. So my question to you is, do you see any way we can intertwine this in our designation in terms of levels of care? The whole purpose of that was to improve outcomes. So how do you begin that discussion?
It's not an easy answer.
She's asking hard questions.
I was worried Charleta was going to find a hard question. This is a state that traditionally doesn't like a whole lot of regulation, which is one of its strengths. So I'm still kind of amazed that we have the whole level of care designation process going on. So kudos to you to some degree for that. But I hear it's a program that might need some refinement still. Maybe there's there's an opportunity for refinement to maybe add some of the sort of structural things that could be brought into hospitals that I really wouldn't want to take on personally as a quality improver. So I kind of mentioned it just kind of sideways, but there is a bill in the California legislature requiring anti-bias training for all healthcare workers. And I could almost, while I kind of doubt that it'll be hugely effective, it's maybe effective in just signaling that this is an important thing to policymakers and maybe to the hospital as they roll this out. And maybe, the 10 minutes that people will spend in front of a PowerPoint presentation checking off their multiple trainings that they have to do to be in compliance with things. So, maybe this is sort of an oblique way to enter something that I really wouldn't want to necessarily take on if I try to improve something very specific, but, that signals that there's an importance there's importance to this topic.
Thank you.
Can I add something
Dr.
to that?
Hardeman?
So, I think to your point, at least to me, the important piece of like SB 464 is that it's a policy, legislation that was passed, right? That signals the critical importance of the lives and livelihood of Black moms and babies. And I think, you're right. It's not, and a lot of the work that my team has done in the past has shown that particularly implicit racial bias training does not have the intended impact or, shift the needle. And then sometimes it actually makes things worse because it exacerbates interracial anxiety and sort of these feelings of, well, I scored really high on this implicit bias test, and now, so now I'm biased, and I know that I'm biased, and now what do I do about it? And also, so in the absence of any discussions around sort of what does this mean, there's potential for it to cause more harm than good. And I'm saying this as someone who's working to create these trainings in California. So, but I think it's part of it is I'm not saying, but I think it's critically important to start that conversation, right? And I think for some hospital systems who are already having those conversations on some level, this is one more way to engage folks and really think about, so where do we go next? And for others, it's going to be a little bit of a different scenario, but one that, I still think that there's value, though, in this sort of policy initiative at a state level.
Thank you. Yes, ma'am.
Hi, yes, Dr. Hardeman and Dr. Prophet. I just wanted to come up and just say thank you for this presentation. I think that it really demonstrates, I know, yesterday we've had kind of this conversation about what do we do to make sure that all mothers and babies are healthy and have the best outcomes. And I think what it demonstrates is that there has to be a conversation and a focus on these structural factors such as racism, such as other types of barriers that impact language accessibility, all of that, and specifically needing to be that increased focus on Black and Indigenous women if we're going to drive down those disparities. So I think I think what your presentations speak to is kind of countering this narrative that it's a zero-sum situation, right? It's not throwing the baby out with the bathwater. It's if we're going to lower the overall rates, we have to focus on those who are most impacted. So I really, really appreciate both of your presentations. And I think even for future conferences, especially with the work that you're doing, Dr. Prophet, and making it tangible, the specific actions that you're doing as it relates to quality improvement. I think a lot of times when we think about how do we incorporate equity into quality improvement, it's this perception that it's this big entire thing, but realizing you can do small things. Maybe you don't have a dashboard, but maybe you have an Excel sheet, to track certain things. Right. And so I just wanted to say that as a one point of feedback, but also just to commend the work that you're doing. So thank you.
Thank you. Yes, ma'am.
Buenos días. And thank you so much for creating a space for productive discomfort. Because sometimes we shy away from discomfort. We're like, I don't want to touch it. And also thank you for anchoring us in history. Because if we don't know where we've been and how our history shapes the systems and structures that we have now, there's no QI project that is going to help us solve that. So I think that as scholars and clinicians, we tend to focus on fixing things that can be measured quantitatively. It's just easier. And we favor programmatic solutions, even if the problems are relational. So I would love to hear your thoughts on how do we think about relational solutions to relational problems rather than just programmatic solutions.
Yeah, it's a really tough one.
Yeah.
So, I liked your comment about the space for discomfort, because, for me, this is really a space of discomfort. Like, oh, Christ's sakes, I'm from Germany, like we have a slight history of not being really good with regard to race relations. I came to this as a quality improvement person almost more, because like disparities are really part of the variation between hospitals. We see variation between our hospitals in almost anything, and disparities contribute to that variation, and sort of our goal is always to stamp out variation as much as we can. And so we kind of enjoy the non-relational approaches to being able to, just through standardization, like the ROB colleagues did, or things that you can do for instance, in breast milk feeding, where like everybody gets a certain amount of support, gets certain things in order to drive up breast milk feeding rates and sustainability of that. So in many ways, I've been trying to favor, maybe out of avoidance of the relational problems, but I've been trying to favor these technical solutions because I think they can get us a pretty far way with relatively fast improvements or reductions in disparities. And on the other hand, I've been kind of worried about some of the relational parts because they're really hard, right? And they speak to things, as Rachel said, that have been kind of in the soup for 400 years. Mm-hmm. And it's like going to be very difficult to sort of easily overcome those. But I think a degree of humbleness, maybe an openness about the elephant in the room. And that's why I kind of mentioned the signage. Could we have some signage? Just like, we respect people of all race, ethnicities, or backgrounds, to just kind of like just put it out there and remind staff. And then also as you interact with patients, maybe just to name these things or discomfort that you might have or somebody else might have, might be sort of a step forward. It's much harder to quantify those things, right? And like for us as a QI organization, it gets very difficult. But certainly those kind of trainings and respectful respect and those kind of things can be taught and probably need to be taught. But it's more difficult to quantitatively assess them, and surveys try to do that, but those can be kind of tricky.
I'll just add, I think that's a really important and difficult question. But, one of the things that even, we as a research team, my research team tries to do is have conversations continuously about sort of what we value and what's at stake. And I think reminding ourselves of that and having that question, whether we're doing a qualitative study or quantitative study or both, is really important. And I think that can be brought into the QI process a lot more. And also, it's a conversation about what are we willing to give up so that everyone can thrive. And I think we're not there yet. Power is a really important part of our society and sort of human nature. And the discussions about sort of relinquishing power or who should be allowed to have power and who should lead are really challenging to have. And it's about money and it's about resources and who gets to stand up in what rooms. And until we are able to have some really honest conversations with ourselves about, for instance, who's in the C-suite, right? Then
those relations and that sort of relational piece is never going to be addressed appropriately.
Can I add one more thing? When you were saying this, it kind of occurred to me, if you have a family member on your QI teams who is, most of the family members on QI teams are white middle class people, but like it'll take you a lot of effort to get folks from vulnerable populations because, well, if they are poor, then it's not easy for them to come to the hospital and serve in these mostly volunteer positions. But if you can foster that kind of relationship and then empower that person to actually speak up, because it's one thing to have a family member on a QI team, it's another one to have an actually engaged and a vocal family member on a QI team. But if you empower them to speak up, I think you'll learn a lot, and the team might learn a lot about the relational aspects. Again, it might be difficult to kind of quantitatively measure in the end, but a process that'll take you on the right path.
Okay, I think we have 5 more minutes remaining. Dr. Shavana?
Thank you again. I want to add my voice to the excellence of these talks. I'm sort of drawn back to the designation process in Texas. The designation process in Texas really was to standardize the measurement, or hopefully standardize the measurement of the NICUs. It was a free-for-all before, where somebody hung up a shingle and said, I'm a level 3 or I'm a level 4. And that standardization is not likely to change any disparities whatsoever. I would submit that you need to measure the inequalities and the disparities that exist, just as you have elegantly done, before you can see that there's a change in them. So would you speak to the importance of patient-level, real-time data collection that Jochen, you've been involved with for so long, and how critical that is to the whole process?
And Dr. Shavana, that's exactly what I was saying. We did not discuss that as part of it. And part of the designation process was to also improve outcomes, which is why we were going to collect the data as well. So I think this is important as we begin to think about how we can improve this.
Yeah, I'm at the perinatal part of CPQCC, not the maternal part, and I love all the data we have. I will tell you that it's not, we have standardized data, but it's a big enterprise for hospitals to do that and to collect all of that data. CMQCC, the maternal side, came later, and they didn't really, they felt they couldn't get their OBs on board if they made them extract as much data directly from the medical record. And so they chose the administrative route, which is almost real time, because they intercept the data that's being sent to the state directly from the hospitals. And so within 42 days, I think, from the discharge of a mother, they get data directly flowing to them that they can use. Now the administrative data, because it's for billing, it has maybe a little more weaknesses in terms of how accurate it is, but it's been good enough to drive substantial improvement. And our data is real time whenever somebody submits it, which they have to do at least once a year, but we're hoping to do it like every quarter, and some places do it every week actually. Every time they do it, all of their numbers get updated in real time, so they don't have to wait a year for a report, which is great. Really helps, but we would love to have a way to extract that data automatically from the electronic record and not have to have a person sitting at each hospital trying to do this. So I think there's some barriers to going that granular as well.
Okay, I think we have 1 minute left.
I feel like we
Is there a
ignored
quick
that.
comment?
Yeah, it's actually just a comment and not a
Okay,
question.
please.
I was just going to say that I think, hearing all these conversations is so important, but sometimes it feels overwhelming, like where do we start, where do we move, where do we go? But I'm having these conversations with my kids. And I think if each of us just takes one person that we have this conversation with, we can help continue the conversation at multiple levels, whether it's in the school systems to really focus on the true history of our country, whether it's your work environment, whether it's with your family, or, you know, encouraging your children to understand, you know, what the world really has and the impacts on them, I think is important. So thank you for your work.
Thank you very much for that comment. I just want to simply thank Drs. Prophet and Hardeman from coming from both the East and West Coast to really share their information with our Texas Collaborative. We really appreciate it. Thank you.